Good morning, good afternoon. It's my pleasure to welcome you to the last GS1 Healthcare webinar of 2022. First of all, I would like to introduce myself for those of you who don't know me yet. My name is Monica Soler, and I'm Healthcare Provider Director at GS1 Global Office. I would like also to thank you for your interest in this webinar, and we hope that you will be able to take away some learnings from today's case study, Digital Transformation and Readiness for GS1 Standards from Mackenzie Health, Canada. Next one, please. So before we start, I would like to briefly remind you the competition law caution under which all GS1 meetings are conducted in compliance with antitrust laws. There will be no discussion of pricing, customer or product allocation, boycotts, refusals to deal or market shares. If any participant feels like the group is moving towards an inappropriate discussion, he or she may stop it. And should you wish to read the complete document, you can access it through the link below. Next one, please. So before I start, I would like to briefly remind you that the main objective of these webinars is to provide a platform from which we can share success stories in the implementation of standards in the healthcare provider setting. We also believe that it's a great opportunity for all of you to learn and exchange knowledge from experts from all over the world, and also ask questions to the speakers in real time. So we encourage you to take advantage of this opportunity and interact with them. The next one, please. Some housekeeping for today's session. Just a few practical reminders for you. Please make sure that you identify yourself properly. You can use the rename function to do it with the 3 dots. You are automatically on mute and your video is off. For any quick message or reaction, please use the raise hands function. For all questions, please use the Q&A function. Don't use the chat for this, and your question will be addressed as much as we can. And last but not least, we will appreciate if you could answer the short survey that we will send you after the webinar. Your feedback helps us to improve. So by the end of the webinar, the recording will be available for all of you on the GS1 website, and all the webinars from previous editions are also available in the same space. So the next one, please welcome our today 3 guests, 3 speakers. We will have today Altaf Stationwala, President and CEO, Pamela Richards, she's Program Manager of Surgical Services, and Susan Simao, Director of Pharmacy and Medication Management, all from Mackenzie Health. So let's start the webinar, and over to you, Altaf.
So thank you so much, Monica. It is a pleasure to be here this morning with you from Toronto, and I guess this afternoon for all of you in Brussels. It's a pleasure to give you a perspective on Mackenzie Health's journey as we've looked to adopt GS1 standards and how we've built some of that infrastructure sort of as an enterprise, but also specifically a case study in pharmacy that Susan will do, and then a further case study in our operating rooms that Pamela will do. If we go to the next slide, please, a little bit about Mackenzie Health. So we are located in the Greater Toronto area. We service a catchment area of well over 600,000 residents. And we've obviously been on a significant journey of growth. So about a year and a half ago, we opened our second hospital, which is what you see to the left, the Cordelucci Vaughan Hospital. Prior to that, we were a single hospital servicing 600,000 residents. So as you can imagine, quite overwhelmed in terms of capacity and volumes. And I would still say we're still quite overwhelmed. Obviously, the pandemic has put major stress and strain on our organization. We also operate 7 community-based locations, some as large as a 120-bed reactivation center closer to the core of Toronto. We have organized our services as we've opened the second hospital into core services, So both hospitals are full service with emergency departments, med-surg beds, operating rooms, and all the diagnostic services. And as you'll see, each hospital then has its specialty focus. Cortellucci in areas like stroke and mental health, obstetrics. Richmond Hill, its focus being in complex care, rehabilitation, and our regional chronic kidney disease program. If we go to the next slide. So our journey has been one of transformation. We have more than doubled in size in the last decade, and really driven by the opening of our second hospital, Cortellucci Vaughan Hospital. Just a bit of a perspective in terms of the Canadian healthcare system. There has been a significant focus to move care out of hospital environments into the community, not that different across sort of the developed world. So this is the first net new hospital to be built in this province of Ontario in over 30 years. So a significant impact that we've had in terms of transforming how care is delivered. And interestingly, we opened in February of 2021 as a pandemic response hospital. So as much as we'd waited a decade for this new hospital to be open and the community was anxiously waiting, as we were in the midst of the third wave of the pandemic and the Omicron wave, we opened as a pandemic response hospital and cared for 600 COVID patients in both our internal medicine beds and our ICU beds from other neighboring hospitals that were overwhelmed. So a very privileged and honorable role that we played to really save, I think, the greater Toronto area hospitals from collapse. And then we opened as a full service hospital in June. Go to the next slide. So the journey of looking at standards and trying to adopt the GS1 barcodes and the impact it has from a patient safety and a patient care perspective was first and foremost driven by our implementation of a new electronic medical record. So if we look at the environment in most hospitals, we don't really have the digital transactional infrastructure. It's remarkable. If you go to a grocery store even a decade ago, you would have seen barcodes and barcode scanners, everywhere. That was not necessarily the case in most hospitals. Our enabling effort was really adopting an EPIC EMR, electronic medical record, and that really started to drive our clinical transformation. We called it an advanced clinical transformation. That was the name of this project, and it really enabled us to deliver better and safer care. It really created sort of one source of truth for information, having one universal record. And I had the benefit at that time, this would have been around 2015, 2016, of sitting on the GS1 Board of Governors, the Canadian Board of Governors. And a unique perspective, because most of my colleague CEOs had no understanding of the GS1 standards and the capability it could provide. And for me, it was looking at what all the other sectors were able to do in Canada and how we had very little line of sight on the products coming to the hospital, supply chain, and in particular, traceability and attaching information to a patient and to a patient record. We go to the next slide. So this is really how our journey started. And as you can imagine, all of these are significant investments. Just a case in point, the new hospital that we built, Cortellucci Vaughan Hospital, was a $1.7 billion investment. Investing in an electronic medical record, depending on the size of the hospitals, anywhere from a $50 to $100 million investment, along with the ongoing costs. So for us, it became a leveraged action of how do we adopt the EPIC system, which we went live in 2017, and how do we leverage the ability in our build to accept the GS1 barcode and start to attach products and devices and implantables to the patient, so that we had a better and safer way to deliver care, but also had that capability of traceability. And what I would tell you is that it actually costs very little extra effort or money to build the capability in our systems to do that. So, we went live with the new EMR in 2018. We again doubled down on that same EMR in our new hospital, and we've really been able to, I think, drive care in a very, very different way. And if we go to the next slide, it kind of just demonstrates where we are. So again, in Canada, we have been slow to adopt the electronic medical record. And without that, you really don't have that transaction infrastructure, whether it's the actual scanners that really exists in every dimension of how we deliver care. So every provider has a scanner attached to them, and they're able to connect information and product to the patient in whatever setting in our hospital. You just didn't have the means by which to do it. So we very quickly moved to HIMSS Analytics Stage 7. So we were the first acute care hospital in Canada to achieve that. And that has really enabled us to have that one source of truth for patient information, but also from a product perspective. But as you will see from Susan and Pam, we are very limited. So as Canadian hospitals, which are on an average at stage 4, as they continue to invest, this is really the opportunity we feel in the Canadian market to start to build standard ability to track product and devices and implantables in our environment. It will be a massively lost opportunity if we actually didn't leverage this investment anywhere from $50 to $100 million per organization to then build the capacity to have a standard barcode across our healthcare system. Next slide, please. So, where are we? You can see we've ticked a few boxes off in the healthcare deployment roadmap. Clearly, we have a strong direction. We have our gap analysis. We've been working with GS1 in Canada around our digital readiness scorecard. And we very much are piloting many things, but we are limited. And this is really, as you get into the case studies with both our pharmacy and our operating room environments, you'll see that Susan and Pam have found workarounds. They've pushed and leveraged the capability as far as they can, but without real government and standard leadership working with our vendors and our suppliers, we're just not in the ideal place. So if we go to the next slide, and then I will turn it over to Susan, and then Pam will conclude with the operating room case study. We do fundamentally believe that product identification, traceability, and visibility are key. The analogy I used when I first got on the GS1 Board of Governors, it was safer for me to provide bottled water in my cafeteria at the hospital than it was to actually do a total hip replacement with a patient in terms of the traceability and the supply chain connectivity to a product. And that, for me, was the biggest eye-opener of why we have to drive this transformation in Canada. So at this point, I'll turn over the speaking to Susan. Susan?
Thank you. Thank you, Althoff, and thank you, GS1, for having us this morning / this afternoon, depending on where you are in Canada or in the world. So just before we move on to the pharmacy case study, we thought it would be helpful just to review with our audience the main intended uses of barcodes in the healthcare context. And one of the main things that I think most of us identify with is the use of barcodes in product identification and the key role in safety that we observe with that. But in addition to that, there's a huge role for the use of barcodes in inventory control and traceability, which helps us support our Accreditation Canada standards and other standards in the events of recalls and other adverse events. And of course, the last piece, which we found quite helpful, is that usefulness in creating product visibility across our organization. As Althoff described, we are a multi-site organization, and it's extremely useful to create that visibility, particularly for us in pharmacy in the context of all the medication shortages that we manage. So I'll touch on that a little bit later as well. So moving on to the pharmacy case study, we can have the next slide, please. What I'll do over the next few minutes is really just describe pharmacy's journey for barcoding, and I'll highlight some of the foundational elements that were necessary for us to have in place at the start of this journey. And then I'll talk briefly about our assessment of our current state and what gaps we had to address in order to construct that single source of truth and that resource of the barcode standard. And then we'll touch on some of our implementation, our processes and resources that were instrumental in making this journey a success. And then finally, I'll show you some of the tools that we have for monitoring and what some of our uptake has been as well. We can move on to the next slide, please. So As Althoff mentioned, the journey at Mackenzie Health really started as one that was very much centered around our quest for achieving the ultimate in patient safety, which was the barcode medication administration. And as he described, one of the key investments, strategic investments we made upfront was our EMR with Epic. And that was integral to building the infrastructure that was necessary to support this vision. For pharmacy, it became evident quite early on that in order to grow this vision and to support it safely and efficiently, we really needed to make an investment in pharmacy automation, both within the central pharmacy as well as in the patient care areas. And that's when we partnered with vendors such as Omnicell and Codonics to make sure that we were leveraging the use of the barcode at every step throughout the medication management process. So the automation not only set us up nicely to create that visibility across the organization for the inventory, but it also helps support those requirements for traceability in the events of recalls, our ability to generate barcodes in some instances. And it taught us that, while we were on this journey for achieving our vision of barcode med-admin and full traceability, it wasn't going to be as simple as implementing systems that could read these barcodes that we would start using. Because quite simply in Canada, the barcodes weren't always there. Next slide, please. So simply put, what we learned was that pharmacy was going to have to find a way to generate barcodes in a standardized manner. And we partnered early on with GS1 Canada to learn about the importance of having a barcode standard, what the elements of that were, and how to generate consistent information in each of the barcodes that we were going to be applying to products. And that was necessary because we recognized that there was a couple of buckets that we would always have to be barcoding. So we repackage products often in our pharmacy, as most pharmacies do. In hospitals, we repackage to the unit of use. We compound some of our own products, whether they're sterile or non-sterile. And so we knew that there was going to always be a need to generate barcodes for these types of items. But what we found out very soon was that there was also a lack of barcodes on the products that we were receiving directly from manufacturers. So what was supposed to be ready to use unit of use items were coming to us with either no GS1 compliant identifier, or they had a valid identifier, but other key elements such as lot number and expiry date were missing from those barcodes. The bottom line was that in Canada, the manufacturers really are not held, they're not legislated to provide any sort of standardized barcode on the unit of use or on their products. And this was becoming a challenge for us. We can go on to the next slide, please. So recognizing that we had these two buckets of need and that we were going to have to find a way to generate barcodes in not only a standardized manner, but also safely and efficiently, we did make some investments in automation to support the generation of barcodes. And we invested in the automation because it became apparent that the more automated you can make that process, the less risk of human error. And we've sort of really promoted within our staff that the generation of a barcode is one of the riskiest products, given that it's being used at the end state in verifying what we're administering to our patients. So we've invested in automation to support our IV compounding, and that generation of barcodes comes automatically. We've been able to apply the GS1 standard. But more sort of broadly, and I think many of you from the pharmacy world can relate to this, we have automation to generate automated barcodes for our oral solid packaging and repackaging. And that's the Swiss log robot that you see on the right, but we do have other automated packages as well. What we realized, though, is that there was this whole group of things that were not going to be captured no matter how much automation we put in. And so we've invested in the HealthMark package software to help support barcoding of other products. And this has become really a workhorse for us. We can go on to the next slide, please. So this next slide sort of gives us a glimpse at where we're at with achieving full traceability. So I'll let you guys review that pie graph that we have and take it with a little bit of a grain of salt, but I'll bring your attention to the blue section of the pie graph, which really shows you the proportion of items that are being administered to patients that do not have a lot number or expiry date affixed on them. And the reason I want to highlight this section is because these are products that by and large we receive directly from the manufacturers with an identifier, with a G10 identifier that our system, that Epic and our automation can recognize. And I want to bring your attention to this because we at Mackenzie Health have made a conscious effort, as do many of our colleagues, to not re-barcode these products with a fully compliant GS1 barcode that contains the lot number and expiry date. And the reason we've chosen not to do that is because the risk of misidentifying the product bears a far greater risk than not having a lot or expiry in the event of a recall. So we leave them alone. If they come to us with a valid identifier, we use it, and we don't add in the lot number and expiry. The second portion that I'll bring to your attention is the purple piece. And, you know, that seems like a pretty nice success story. 45% fully traceable, that's great. Unfortunately, I don't have the exact breakdown, but I just want to bring to attention that in that fully traceable bucket of 45% are all of the items that we within the Mackenzie Health pharmacy repackage and compound. So embedded within that 45% is items that we have to barcode because we're making them. And then there's a small proportion of that comes to us directly from the manufacturers with a fully traceable barcode on the unit of use that we do not need to manipulate. So the bottom line is that there's no mandates for legislation, as I mentioned before, in Canada, and providing a standardized barcode on the unit of use, there's very little traction at this point to get all of the elements embedded in those barcodes. And despite lots of advocacy from our group purchasing organizations such as Health Pro. We can go to the next slide, please. So I just thought it might be helpful just to ground sort of how we're using the barcode across the process. So just pulling it all together, every time a product is received, we have staff who scan every single item to make sure that the identifier is still valid, because without a single registry, that's being updated directly from a central source, it's up to us to validate that manufacturers haven't made any changes. So that happens for every single product, every single time it's received. And then if there's no usable G10 on that, then we have a process. Those items get segregated to get barcoded. Then we use those barcodes to restock medications into our pharmacy automation. Then we also use the barcodes to verify that we're dispensing the correct products when we're releasing them from the central pharmacy automation. And then again, we use the barcodes along the path when we're restocking, and we have automated dispensing cabinets in every area of our organization, including the OR where we have automated anesthesia carts. So we use the barcode scanning to verify that we're stocking the right products in the right places. And then finally, when the nurses are withdrawing the medications and administering them to the patients, they're doing that final scan. And it's at that point that the administration information is being documented in Epic. And that assists us with full visibility. And then just to highlight as well, since Pam's going to be talking about the OR, just what happens in the OR as well. With anesthesia removal. So as I mentioned, we have the automated anesthesia carts in the OR. When items are removed, the anesthesiologist will scan that onto the Codonics printer that we've implemented as well. Codonics printer adds an additional layer of safety by verbalizing the drug that the anesthesiologist has chosen, and then generating a label of the specific mixture or the specific compound that the anesthesiologist has prepared. And that label is scanned to document the administration into Epic, and thereby documenting the lot number and expiry of the exact product that's been administered to the patient during the procedure. So we can go on to the next slide, please. So what is the impact to our organizations to implement these barcode standards? I think not only do we need standard processes and workflows, and I'll touch on that briefly, but I think the big story here is that the amount of resource required in order to manage having a standardized barcode system. So I've talked about a number of pieces of automation. Each piece of automation has its own formulary that needs to be managed, and including Epic, including each piece of in central pharmacy and the software that we have in patient care areas. So we have resources maintaining those formularies. And I'll just mention here that because we were an early adopter in Canada with Epic, we had to also do a lot of advocacy with our vendor that provides the clinical alerts and the product information for Epic, which is First Data Bank. So lots of advocacy there as well to get them to be able to provide the GS1 standard or G10 even information for the products that we were building into the formularies. And they've come a long way throughout the years, but again, they're working without a central database to work with. Again, resources to create and verify the barcodes, maintain those formularies, troubleshoot issues when they come up. So we have approximately 4 FTE across across all of our organizations, and that's just one organization. So imagine the impact when every organization in the country is trying to do this as well, and there's no one single source of truth, one single registry to draw on, not only to build the systems, but to maintain when there's changes. We can go on to the next slide. And just as significant as the resources I mentioned, the workflows and the processes, this is just an example, and I'm not expecting anyone to read this, but this is our process flow map for affixing a barcode on one single product. So this is all the steps that someone needs to follow, all the steps that require human touch and bring with it the risk of human error. And we can go to the next slide, please. And I'm not going to spend a whole lot of time on this slide, but I did want to share it to demonstrate that our organization has a very high rate of adherence to barcode scanning at administration. And we have since we implemented 5 years ago, something we're very proud of. But I think what it speaks to is that it's not for naught, right? So we've made these investments, we've done these workarounds in establishing a barcode standard, and that's because we know that it's going to support the patient safety journey. And we can go to the last slide, where I'll just spend a couple of minutes just summarizing the pharmacy case study. So the benefits of applying a standardized barcode are undeniable. I think from a patient safety perspective, absolutely, and it also supports the automation of workflows for our employees, for our providers, and just supporting that patient safety journey. So at our organization, I'm not keen about reporting numbers with medication safety incidents. However, what I can comment is that we do track them, trend our med safety incidents at our medication safety committee, and we've seen no misadministrations, because we do have the barcode MedAdmin in place. In pharmacy, we use the barcode to ensure quality in our dispensing and storage processes. We do audits, and we've seen immeasurable benefits in terms of the inventory management across the organization. So particularly, as I mentioned at the start, with all the medication shortages that we're managing approximately 200 at this point in time. And it's just been unbelievable to have that visibility that the barcoding affords us. We've had a number of recalls where we've been able to drill down exactly to the patient level and identify which patients would have been affected, where in the past we weren't able to get to that. So I've already spent quite a bit of time talking about the challenges with barcoding in the Canadian environment. So I'm not going to spend a whole lot of time on that, but I think, key here is really highlighting that there's several databases that need to be maintained. There's manual processes for barcoding, and of course, the tremendous number of resources that each organization is investing in doing that for their pharmacy and their medications. But perhaps the most significant challenge is every time we need to touch a product to affix a barcode to it is the risk of human error. And so really that is the greatest challenge. Some lessons learned along the way. We started early with our barcode standard. So recommendation is really, if you're thinking about embarking on this journey and you haven't already, pick a standard. We chose GS1 and build everything around that standard. Make sure all your systems talk to each other, and everything, all the automation can read and store the data that you're generating. And then just before we move on to the OR case study, and I'll hand it over to my colleague Pam in a minute, just two key pieces for the pharmacy world. Really, we need to advocate for legislation in Canada to mandate the manufacturers to provide those barcodes. And we really, really need a global registry that not only informs our formularies and our databases, but also helps maintain them up to date. Thank you for your time. I'm going to hand it over to Pam Richards now to tell you about our OR.
Thank you, Susan, and thank you, GS1, and thank you to all of our attendees. It's great to be able to present to you. I'm not sure who exactly our audience is, so I will just share with you a little bit about the operating room. It is a place where we provide care that really focuses on accuracy, efficacy, and efficiency, all within the time frame of please make sure I can serve every patient that I want, that I have booked today. So implementing a change process can be challenging to have individuals join us in a positive way. So I'm going to share with you our journey to success. We're very proud of how far we've come, and we'll start with the next slide. Thank you. So using the same model of implementation as pharmacy used, I will go through the four steps, and I'd like the next slide, please. So beginning our journey was removing a manual process. Before Epic, we had the implant book where nurses took it into the room, they collected a patient label, they placed the implant stickers from the manufacturer, the patient label, and all the surgery information into one of those books. And we kept it handy and we kept it safe in case there was a recall. So that's where we began. And next slide, please. So how did we begin our journey? So there were three key collaborative entities. Plexus is our shared service organization. They represent about up to 30 hospitals in the province of Ontario, and they're a procurement to payment service. So we purchase everything through our Plexus system. And so they were key because they had the master item file, they had the beginning of the database. We were the drivers of change, and Epic facilitated our ability to implement the barcode scanning. We did have 6 key inputs to help us achieve our goal of at least a unique database for us to use as our own hospital's purpose for implementing Epic. Next slide, please. So how did we create that source of truth? I mentioned Plexus, so they were the people with the infrastructure to hold our unique identifiers, our information to create the barcodes for scanning. We worked with all of the vendors, our major vendors for orthopedics and every other service, and Epic was involved in relationship to accepting the data that was created through the initiatives. So when we look at our accomplishment, we were fortunate that our vendors collaborated with us to create GS1 compliant scannable barcodes, and Epic also was able to create the foundation and the system so that the barcodes could be received in the system for the nurses to verify. Next slide, please. So it took us approximately 6 FTEs, 6 months to create. So 6 full-time people to create our database. There was the build, there was the testing, there was the ensuring of accurate information. And so we were ready to go live at the beginning of Epic. And we were very proud that we had 89% of all our consumables available to us. And we had 100% of our major implant providers. So we were in great shape from day one. So we were able to prove to our naysayers that scanning really did make a difference to patient care. Next slide, please. We did work from a different premise than pharmacy. If there was no barcode to scan, then we didn't scan. We didn't have the resources to create barcodes, and we felt that with our focus on the bedside, we actually were concerned about the risk of inaccuracies. So in this picture, you'll see that our instruments, any supply that we procure in bulk, and our equipment do not have barcodes. And these are important aspects for us to think about going forward, because anything that we do to the patient, we need to have traceability in case there's an untoward event for our patients. So right now, there is no universal database for any of these inputs into patient care. Next slide, please. So if I actually take you to the bedside right now, I'll just briefly describe exactly what happens to get from an item that we want to use for a patient into the patient's chart. So Epic accepts an interface from our Plexus. It's a master item file where we have all the information to be able to compare against the barcode that we will scan. The one thing that I will tell you about that master item file is that because it is not mandatory in Canada to submit for a scannable barcode, if there is no barcode submitted from the vendor to our Plexus group, then we have to advocate as an individual hospital with those vendors to provide, and then we work with Plexus to have it in our system. We have to do the testing ourselves. So we actually have an FTE that is assigned to support that. But when we do have barcodes, scannable items, the nurse scans it into the system. If the Epic system checks to make sure that it's an identifiable item, and it will pop up on the screen. The nurse verifies the product with the scanned item information, and she accepts it, or he accepts it, into the chart through Epic. So what benefits have we received? Well, we have greater traceability. And you can see that from this slide that our case costing has improved. Our supply chain replenishment is a little bit simpler. We have much better data in our patient's chart, and we're ready for recalls if we unfortunately need to address that. Certainly with the implementation of barcode scanning, we were able to prove that barcode scanning is transformational from care at the bedside, and it certainly helps beyond the bedside. However, next slide, please. We still have work to do. There are still opportunities. You've heard it twice or maybe 3 times that it's not a mandated responsibility from the vendors to submit data that can be created into a barcode. And so some vendors use a different, some vendors don't submit. And we also have different standards that are possible to create a barcode. So if we don't have GS1 standards that were used by the vendor, we can't barcode that either. So there's a multitude of things that we could do to improve just what we currently have. Next slide, please. So where have we come? So you've heard me talk a little bit about the benefits and a little bit about the challenges. I'm just going to summarize by saying we are very proud of how far we've come, and that we've done that because we've had essential partnerships that work very diligently with a focus on our patient and making patient care better. The other piece that I will plug for any of you who are decision makers about equipment, having the right equipment is essential. We were very fortunate to have whatever scanner we needed to support care. We have wired scanners, we have wireless scanners, and it makes all the difference to make it easy for the end user to actually scan our patients and scan our products. Our next steps, you've heard it from us before, is a national unique database, and it's something that we need to work hard on. Next slide, please. So when we think about healthcare, it does extend beyond the moment in which we deliver it. Barcode scanning, absolutely, in our experience, has created a transformation in the way we provide care, the way we take accountability for the care we've provided, and any follow-up that we need to do. So when we look at barcode scanning, we have already achieved patient care excellence. Inventory procurement and recall processes are easier. We've got clinical quality assurance, and we definitely have the ability moving forward to improve industry quality standards. I'm going to turn it back to Susan to give you one final message. Thank you.
And the next slide, please. Thank you. So just in terms of an ideal state, we just wanted to summarize. Obviously, you've heard from all three of us that really what we're looking for is a universal set of standards and a central registry. And I think, you know, when we reflect on what are the essential components of that, it's really monitoring, understanding our environment, and understanding what our current situation and our gaps are, making sure that we're clear on what our priority is, that commitment is to patient safety and putting our patients first, and what the implications are of not having these standards in place. Partnering with people like GS1 and other stakeholders. There's a lot of advocacy and a lot of partnering, as you heard from Pam as well, around partnering with our vendors and our different stakeholders through Plexus and so on. And then finally, that regulatory oversight, which is sort of missing in our environment. I'd like to thank you all for joining us today, and that's the conclusion of our presentation. Thank you.
So Monica, we'd be happy to take questions from the guests at this point.
Yes, sure. So thank you very much, Altaf, Susan, and Pam, for sharing your experience at Mackenzie Health, also for being so brave to be early adopters. This is not easy, and we encourage you to follow in this direction. So we have just seen that the scanning of GS1 standard barcodes in both the pharmacy setting and the operating room areas of the hospital has a very beneficial impact, both in patient safety and also the different processes that support the hospital clinical and non-clinical activity as well, as Susan pointed out at the beginning of her presentation. So we will now move on the question and answer session, which I remind you, you can ask your questions via the Q&A function. And let me break the ice. There is one question on the chat from our colleague Jesper. So the question is, you have a high level of compliance by using barcode scanning at point of care. Which initiatives have you completed to achieve this great result? Who wants to answer this first question?
I'm happy to start responding to that, and I'm sure my colleagues will jump in as well. So one of the things that Pam mentioned that I'll start with is infrastructure. Making sure that the users have the tools that they need in order to be able to do it successfully. And there was a lot of scanning, a lot of discussion about this. I remember when we were implementing the EMR, lots of conversations about, do we use WOWs? Do we use rovers? Do we need a computer at every bedside? And that was the commitment that we made, right? It was a computer at every bedside with a scanner that can get to the patient. And we learned from other organizations that had implemented BCMA ahead of us, and we leveraged those learnings as well. But I think first and foremost, it's making sure they have the tools. And we saw this, the other piece that I'll add in is continuous monitoring. And that dashboard that I showed you, it's a live dashboard that we have right in Epic. Every manager sees it. They can go into it. They can drill down to the exact patients and exact administrations that were not scanned, and follow up with the nurse that didn't do the scanning to understand what the barriers are, We made it very easy for people to report if barcodes weren't working. They can do it right from the MAR. They can send a message to pharmacy, and pharmacy will investigate why that barcode's not working and resolve that issue right away. And we had that commitment, and we partnered with clinical informatics early on to remove those barriers and challenges so that we didn't get into a state of complacency where people felt like, it doesn't work anyways, I'm not going to do it. And the managers every day were reporting and accountable for why are my rates low? Why are my rates low? And we removed those barriers quite early on, and just maintain that sustainability. So now what we do is we continue to monitor it at our medication safety committee. And we did have an area where we were dipping down, and we took a look at it and realized, well, the wireless wasn't working well. And again, it was a matter of making sure that the users had the tools that could work and support the process. And we did that as well. So I would say infrastructure, continuous monitoring, and removing the barriers.
And Monica, if I could just add a different perspective as well. And clearly we made decisions and we engaged the frontline users as we've designed every dimension of our technology adoption, whether it's the electronic medical record, the infrastructure that goes into it, the devices. But I'd also maybe reflect in a different way. So if we look at healthcare, it is a vocation, it is a calling, and every provider that comes to a hospital or any healthcare setting, they want to do the best job possible. They want to provide the safest and best care possible. And the more we can do as leaders to ensure that we provide that environment, that we provide all the tools that they need to do the best that they can, it really does enable them to get a higher degree of job satisfaction and obviously, deliver the best care to your community. A key important stat, we fundamentally believe this, that the technology and the adoption of the things that you see here at Mackenzie Health, we have been able to recruit more staff and we've been able to retain more staff because we create an environment in which they can provide safe care. So think about this, and every part of the world is facing a shortage of health human resources. We recruited well over 2,000 new staff for Cordalucci Van Hospital in the middle of the pandemic, and we continue to grow by about 500 to 600 new staff every single year, whereas my peers around us are struggling to even keep the staff that they have. And I believe much of what you're seeing here empowers the staff to do the best they can. So it actually becomes a very powerful health human resource strategic advantage as well.
Thank you, Susan, and thank you, Altaf, also for your thoughts, for sharing your thoughts. And this is quite important, what you have already mentioned. So we have more questions on the chat. Are you considering RFID technology to further improve your processes besides the barcode itself? This is just focused technology question. Who wants to answer this one?
I can answer, Pam. I don't know if there's anything in your area, but we do use some RFID technology with our kit and tray management, and we are just starting to take a look to see if there might be some opportunities to further support that in the OR.
Thank you, Susan. So we actually have a fair amount of our equipment that have RFID tags. We actually, sitting at our communication station, we have I'm going to call it an RFID map. So if we're looking for a specific item, so if we need IV pumps, if we need compression stockings, we can actually identify where in our institution they are sitting so that we can follow up if those are needs. It's an amazing tool because rather than waiting for 45 minutes to start a patient's IV, we know within seconds where it is and where we may be able to secure it. So we do have other technologies that we use for patient care. So we're fortunate in that our implementation really focused on using as much technology as we can to transform the care we give to our patients.
Thanks a lot. So there are more questions on the chat. There is one from Madhua saying, are you able to track patient outcomes comparing different devices or procedures in line with value-based care?
That actually is our next step. Go ahead, Alta.
So what I would say is, as we look at sort of the barcode technology, we haven't really done a deep dive review of the outcomes, but I think it's intuitive to understand that the amount of traceability. And I think you heard from Susan, just at the bedside, that scanning and that dimension and that compliance has absolutely improved the quality of care. The highest risk element of the medication management process is that last step where you're administering that med. So the fact that we have that closed loop medication effort right at the bedside is critical. The other dimension, and we've received a number of awards from HIMSS around the outcomes as we've adopted more technology in our electronic medical records. So we have dramatically improved door to needle time, for example, for stroke patients. We've had impacts on COPD patients and CHF patients in other case studies. So there's no two ways about it, that barcoding and the right technology deployed in the right way. And I stress this, you can buy anything you want and a vendor can sell you anything they want. But if you don't deploy it with the efforts of your frontline staff and ensure that they own the workflows from a patient safety and an efficiency of care delivery, you won't be successful. And in my view, that's where Mackenzie Health has really succeeded in its investments to date.
Thank you, Altaf. Now there is a question that is quite interesting for many countries because there's no still there. You have mentioned about a national repository, a national registry. So how will that be built? Will you do that by yourself nationally or use something already existing? Will some Canadian authority be in charge of this?
So this is the $1 million question. Where do we start? And what I find amazing is many of the same vendors who work in the Canadian environment in other jurisdictions, such as the UK or Australia, where things are more defined and mandated, have complied. So, we do need leadership. We are fundamentally a publicly funded healthcare system. And I think, the funders have to push the vendors and many of our suppliers to achieve some degree of compliance. You've seen, the obvious business case, the resources in Pam's portfolio or Susan's portfolio, the number of FTEs that are used for procedural steps around, ensuring that standard is in place. You try to extrapolate that across the system. It's obvious from a business case perspective that there are dollars to be found, but more importantly, from a patient safety perspective. And I would suggest to you that the other revealing moment for us not having a universal standard was during the pandemic when we had a shortage of predictable supply. And not having line of sight, submitting manual reports to government, i.e. counting products every single day, and then inputting them in a spreadsheet. Pam and Susan had to do that many a moment. So we do need government leadership at the end of the day, as we are publicly funded to get that national registry in place, Monica.
Yeah. That also applies to many countries. They are dealing with the same wish and hope it will come soon. So this is another question for Susan, but you can all three answer. The question is, Susan said that Mackenzie Health decided to go for GS1 after reviewing a number of standards. Would you recommend GS1 for other healthcare institutions and why? And what are the main benefits of GS1 compared to other standards?
So I can kick this off. Just to be honest, that was a while ago. I can't do an apples for apples comparison, but really in terms of the standard, having that global identifier and then the flexibility to add in the lot number and expiry date, really from a healthcare perspective, healthcare environment perspective, having those elements in the standard barcode is key. Having the flexibility to use different symbology as well in applying that, whether it's a 2D or a linear barcode. That's been very helpful with the different technology that we've been using as well. So from my perspective, yes, absolutely. Altaf, I don't know if there's anything that you would want to add from the GS1 perspective and the work you've done there, but absolutely from a healthcare perspective. And then there's the additional flexibility of adding in the serialization, adding in which we're not quite there yet, but we have those capabilities, and also the location identifiers, which might be a next step for us.
Thank you, Susan. And there is another question on the chat. It says, great leadership. I agree. Where are the supply chain organizations on this? Plexus is your partner, MMC Health Pro.
Yeah, I mean, you know, again, there are extended procurement arm, and you know, we can put any dimension that we want through them in an RFP on any product or consumable that we choose to acquire. But if the industry doesn't have to comply, they won't comply. So, you know, it's not a mandatory requirement, and the vendor community is pretty clear, you know, that it all comes at a cost. And, you know, if all your organizations aren't in the same place, so, you know, many hospitals have not gone that deep into an electronic medical record, there may not be the benefit for them. So why would they want to pay that premium for this universal standard? So, you know, we need to move as a system and a sector. I think, you know, the benefits are obvious. That's what I have found so shocking in my 8 years, you know, being affiliated with GS1 Canada. Like I just think it's a no-brainer. But you know, we continue to still struggle because you can't do it in a piecemeal basis. So you've seen in our environment, yes, we've cobbled it together, but it is far from ideal, and it's not sustainable. So at some point, unfortunately, I will have to say to Susan and Pam, we can't afford any more FTEs to continue to deploy this because it's just not efficient to do that, you know, and that's the challenge. So, you know, if Pam wanted every dimension of her operating room, you saw that image connected to the EMR, it's never going to happen because we will not be able to afford it. So, you know, back to where we need to go. We do need one approach here, and you know, adding it to an RFP through our suppliers like Plexus and MMC, I just don't think it'll happen without government support.
Okay, thank you, Altaf. So in the absence of legislation, what supports exist to advocate for barcoding standards for both medications and medical supplies, medical devices?
So I'll just tag on to Altaf's comment, and maybe just tying into the last question too. I think we do have that gap. We need that concerted advocacy that Altaf's mentioning. Our group purchasing organizations like HealthPro, they're trying, right? They are putting it in the RFP. They are trying to leverage, but it's very challenging. As you saw from the percentages that I presented, there's still a very small proportion despite those efforts. But there is some advocacy happening at the GPOs and through our partners and the work that Pam did through Plexus and the vendors. But it's their workarounds.
Thank you, Susan. Any other comment from Altaf or from Pan? Just to conclude, any wish for Christmas?
No, look, I think the other narrative here is that there are entire health systems that have achieved this in other jurisdictions. And again, I've seen very powerful videos from GS1 UK and GS1 Australia that really demonstrates, you know, what the end state could look like. So we don't have to look that far. You know, the benefits from a patient safety perspective are important. The benefits from a cost and efficiency perspective are important. But I would also say that other dimension that we now need to start to push in front of our funders and our policymakers is this is a sustainable ability to improve health human resources, which is today the most current, most powerful narrative that exists, not just in Canada, but globally. So how do we keep healthcare workers engaged? We keep them engaged by enabling them to do their jobs better and safer. No nurse or physician ever wants to harm a patient. And if we can give them the tools and the infrastructure to do that, we will just keep them engaged or re-engaged back into working in healthcare, which is unfortunately where they're running away from in all of our environments.
So thank you very much for sharing these thoughts with all of us. I think we all agree on this, and maybe we can imagine of a near future where we can have all these standards implemented in order to improve this patient safety. So unfortunately, time has run out very quickly today. So I would like really to thank you, our three speakers today, for sharing your experience and your knowledge and your thoughts with all of us. And also we encourage you to continue in this promising direction at Mackenzie Health. I would also like to give a special thanks to our colleagues at GS1 Canada, Alicia and Francois, for bringing this project to a global audience, and of course, to all of you for attending these webinars. And well, finally, we'd like to take this opportunity also to wish you a very happy and healthy Christmas. Thank you all, and good afternoon.